It's Friday, the 17th of February, and this is the Hot Topics podcast. Welcome back to the Hot Topics podcast from MB Medical. Thanks for joining us, everyone. Neal Tucker here, as ever, to take you through the next 20 minutes or so. Straight down to business today. We've got lots to get through. Coming up later in the podcast, we have the next in our series of interviews. Just one more thing. We will be posing our 3 questions to Dr Katherine Hickman, who is a GP, but also chair of the Primary Care Respiratory Society. We'll be chatting about hot topics in respiratory. Before that, we'll be having a look at the latest research. 3 studies today. We'll be looking at one on pharmaceutical company promotional spending for their drugs. We'll be having a look at one on using atropine to delay myopia in 4 to 9-year-old kids. You couldn't make it up. And a paper on whether cardiovascular risk tools are accurate for cancer survivors. First, let's have a think about the news. What's going on in general practice? More of the same, perhaps. So, pensions are still a problem. Capita still suck. The government's still trying to give GPs a really bad deal in the next contract. We'll all be stuffed by inflation, but particularly if you're a partner and if you are trying to run a practice, you're going to have to jump through ever more tiny hoops to get some money. On the positive side, maybe there could be some more cash coming into general practice soon if only we get on board with the Treasury's new idea. To make the country more productive and to generate more wealth, what we need is more people working. Now, one way the Treasury could try and do that is by incentivizing people to work. You could try and change the rules so that people in lower paid jobs aren't financially disadvantaged from working. You could try approaching the group of older middle-aged people who during the pandemic realized that working was for losers and help them back into the workforce. Or you could get GPs to sign less people off sick. Ration those sick notes out. Each GP only has 2 a day. Here you go, Tommy, you've got non-specific back pain and you're probably faking it. You get the first one. Philippa, you're a bit sad because your cat's just died. You can have the second. Angie, you've just had a car accident and you appear to have a bleeding stump at your knee. Well, I'm sorry, we're fresh out of sick notes here, but I can give you a tourniquet to stop the bleeding and the job centre will be able to find you some work where you just sit down. Okay, let's get on with the research. And we're going to start off with this paper from last week's JAMA, looking at the association between drug characteristics and manufacturer spending on direct-to-consumer advertising. I know I like to try and keep the researchers clinically orientated as possible, but I saw this and thought we just need to mention it. It serves as a bit of a reminder about what can go on with pharmaceuticals. And maybe it's because I've been listening to this podcast called Bed of Lies. You might have come across this before. It's in its 2nd series now. It's from The Telegraph. And the 2nd season is all about the UK blood scandal from the 70s and 80s. It's quite long, but that's because it focuses a lot on the people and talking to the people who were affected by the blood scandal, either the individuals who actually became infected themselves or those who had loved ones die as a result of it. And the national inquiry continues. But the really shocking thing that came out in the podcast was that the doctors, the politicians, and the drug companies all knew that these blood products were infected, and they still kept on giving them to patients. What's even worse is that once the government finally said enough's enough, and the UK and a number of other countries had banned the products, the pharmaceutical companies, despite the fact they knew that they had infected products, despite the fact that they were selling non-infected products to the countries that had banned it, they still then got rid of all of their stock in other countries who would still accept it. It's so morally wrong. In the last 20 years in the UK, there's been this big rise in evidence-based medicine. I think most of us buy into the idea about evidence-based medicine. I reckon about 10 years ago, we hit a bit of a peak where there were loads of focus on the nefarious practices of pharmaceutical companies. The rules then changed about how they engage with us, and we had the introduction of official bodies like NICE, who would review the data and the cost effectiveness of medication so that when we as clinicians are prescribing certain treatments, we can be reassured that there's a strong rationale behind them. They should be good medications and generally safe and positive for our patients. It feels like we're no longer at risk of being taken for a ride, and I wonder if that puts us at risk of taking our eye off the ball. So this paper was exploring 150 different prescription drugs with the highest US sales in 2020. The US, of course, is very different from the UK. They have direct-to-consumer advertising. You go there and you can watch on the TV, listen on the radio to adverts about what drugs you might want to go and ask your doctor to prescribe you. And it's big business. So the median total sales for each of these drugs was $1.5 billion, and the median promotional spending was $21 million, of which on average 13.5% was spent on direct-to-consumer advertising. The really interesting finding was that if you were the drug company who had a low added clinical benefit drug, as in it doesn't really make that much difference, you spent more on direct-to-consumer advertising than high added clinical benefit drugs. The associated editorial comes up with a whole range of different ideas about why this may be the case. Perhaps you have a drug that doesn't work for most people, but for some it's going to be really good. But it's all just sidestepping the most obvious and the most likely explanation, which is people will go for the drug that works the best. And if you've got a drug that is not the best, then you're going to need to push loads of advertising to try and convince people to buy it even when it's not the best drug for them. Of course, in the UK, there's no direct-to-consumer marketing, but there are other ways around that. So maybe you'd be funding patient support groups, online campaigns, research grants that you might be funding, educational webinars for clinicians. There are still many ways that manufacturers can chuck some money at the problem and influence people. So for us, this is just a timely reminder, don't take your eye off the ball. I wish that neatly segued into our second piece of research, which is another paper in JAMA published a few days ago, which is the effect of low concentration atropine eye drops versus placebo on myopia incidence in children. But I don't know for sure, but I don't think that this research was driven by the manufacturers of atropine eye drops. In fact, I'm not really sure. It took me a long time to work out why they were doing this study at all. Is myopia that bad? Do we need to try and prevent it? I've had glasses since I was 12, and whilst I can appreciate that maybe life would be very marginally better without glasses, for example, I could see where I'm going when I'm swimming, there are downsides too, as in when I put goggles on and have contact lenses in, I can see all the stuff floating in that swimming pool. It's revolting. So should myopia be just something that we accept, just like male pattern baldness? It's better just to embrace it. The linked editorial points out some of the potential issues with myopia. So 23% of the world's population are affected. The prevalence is expected to increase to 50% by 2050. And it's associated with an increased chance of sight-threatening complications such as myopic maculopathy, retinal detachment, glaucoma, and cataracts. You tend to start developing myopia when you're a child, so approximately aged 8, and that continues to progress until you are a teenager. However, most of the complications happen in older age, perhaps with the exception of myopic macular degeneration, which tends to start in around the 5th decade of life. After doing an admittedly fairly quick search, I couldn't find any data to suggest that using treatments that may potentially delay the onset of myopia leads to less complications when you're an adult. But apparently in the US, they use quite a lot of these treatments. So soft multifocal contact lenses, orthokeratology contact lenses, low concentration atropine. I've never heard of anyone having these in the UK. We just pack them off to Specsavers. Anyway, back to the research. And this was a paper conducted in Hong Kong. It was a randomized, placebo-controlled, double-masked trial conducted on 474 non-myopic children, get this, age 4 through to 9, and they had to have eye drops every night for 2 years. Now, I bet those drops sting. And as the parents of a 5 and an 8-year-old, I am absolutely amazed that the dropout rate was only 25%. So you either had one of 2 doses of low concentration atropine or you had a placebo eye drop. And at the end of 2 years, the lower concentration of atropine, which was 0.01%, didn't make any difference compared with placebo, but the higher dose did. And it resulted in a statistically significantly lower incidence of myopia and quite a surprising difference. So 28% on that treatment developed myopia compared with 53% on placebo. That's a 29% difference. The authors comment that further research is needed to replicate these findings and to help understand whether this represents a delay or prevention of myopia and to assess longer-term safety. So there's lots of unknowns here, but I still can't really get my head around it. Is this a case of too much medicine? I can't imagine a society, particularly here in the UK, where we're going to be taking our young children from the age of 4 and putting eye drops in them every single night to stop them needing glasses. One step too far on the over-medicalisation of society? Specsavers, I think you're safe for now. Lastly, we've got a new paper in The Lancet, and this asked the question if cardiovascular disease risk prediction tools accurately assess the cardiovascular risk in cancer survivors. There's 2 to 3 million cancer survivors in the UK right now, and that, of course, is only going to go up as we live longer and cancer treatments become more successful. Cancer, of course, is more common as we get older, so most cancer survivors are also people that we need to be thinking about their cardiovascular risk in. But then by virtue of having cancer, they are at increased risk of cardiovascular disease. So there's lots of mechanisms behind that. Quite a lot of that relates to the treatment. So chemotherapy increases your cardiovascular risk. So does having radiotherapy, especially to the chest. A lot of the new immunotherapies coming through, they're linked with hypertension, endothelial dysfunction, further inflating their risk above and beyond what you would expect for the shared risk factors that may have driven the cancer in the first place, which are also risk factors for underlying cardiovascular problems. The commonly used cancer tools, both here and abroad, don't include cancer as a risk variable. So can they be accurate still, or do we need to be taking a different approach in this group? Well, this study was conducted in New Zealand using New Zealand-based risk prediction equations that predict 5-year cardiovascular risk in a general primary care population. I suspect, although it's not a risk equation that we're going to be using here in the UK, there will be many similarities. They looked at 14,000 patients who had a primary diagnosis of invasive cancer at least 2 years before they had their first cardiovascular risk assessment. Average age was around 60 or 61 years. So they used healthcare records to follow up what happened to this group over about 6 years, comparing the predicted cardiovascular risk with observed cardiovascular outcomes. The good news for patients and for us is that the risk tools still did pretty well. So the risk was under-predicted by a maximum of 2.5% in men and 3% in women. Although it's not quite that straightforward, because in higher risk groups, there was a small over-prediction of risk by around 2 to 3%. But this seems like sweating the small stuff, because some of the data out there suggests that cancer survivors have a 50% greater risk of cardiovascular events than someone who's never had cancer. So what's 2 to 3% between friends? That feels a little bit like the difference between sometimes when EMIS works out someone's Q risk and you put it into the algorithm yourself. The authors do comment that prediction could be further improved by adding cancer-specific variables. But I reckon for most of us, this is quite a reassuring finding. And even though I'm sure that most of you listening are not in New Zealand, hello to those of you who are, but I think for the rest of us, this just gives us some extra confidence to just keep on doing what we're doing now. While I remember, worth me just highlighting that NB's updated new cancer course is coming out on the 18th of March. That'll be an online webinar. Please join us for that. Also, our new Spring Hot Topics course starts on the 4th of March. That's another webinar. So come along if you're looking for a bit of a general update there. And if you haven't come across MB Plus, you've yet to sign up. That's our subscription service. Normally, it's just over £300 a year. At the moment, there's a Valentine's offer. Don't say no one loves you, NB does. And so there's some money off if you sign up by the 20th of February. It really is a bargain. You get everything that we do online, all included. Next, time for our interview. It's just one more thing. You will be very familiar with this concept now. So we are asking primary care experts 3 questions about what's new and important in their respective fields for us as primary care clinicians to know. And today I am very lucky to be joined by Dr Katherine Hickman, who is a GP up in West Yorkshire, but she's got many strings to her bow. So what I'm going to do is I'm going to let her introduce herself. Hi, Katherine. How are you?
Hi, Neil. Thank you so much for having me on today. So I'm Katherine Hickman. I'm a GP in Bradford and respiratory lead for West Yorkshire ICS. And in my national roles, I am executive chair of the Primary Care Respiratory Society and also primary care lead for the National Asthma and COPD Audit Programme, which currently is just in Wales.
Well, you sound like a very busy person, so I'm very grateful that you've taken the time to come and join us today. And it also sounds like what you don't know about respiratory disease, we don't need to know. So you're the best person to be asking this to. So let's get down to our 3 questions then. So question number 1. So can you tell me one thing that we need to know about in general practice regarding respiratory disease? And I'll let you, you can pick whatever you want to talk about.
So I suppose my main passion, and it does actually really tie in with the work that we're doing around the Impact and Investment Fund and improving respiratory care, but also saving the environment at the same time, is to really focus on SABA over-reliance for patients who have asthma. And I think what would be good for everybody to stop and think about their patients who have a diagnosis of angina. I guarantee that if you go into your repeat prescriptions of those patients, that they will be getting 1 or 2 GTN sprays a year. You go into your asthma patients, and the majority of your patients will have 6 or more SABA inhalers a year. Every time a patient takes a puff on their SABA inhaler, it is no different to a patient having an angina symptom and taking a spray of their GTN. We don't normalise over-reliance of GTN spray, and we mustn't do it for asthma because over-reliance on SABA inhalers is a sign of poor asthma control. And it's nobody's fault. It's become accepted practice, but it's time that we need to change that. Patients have normalised taking it. We as clinicians have normalised prescribing it, but it's time that we stop and we start to think about, does that patient know why they're taking a steroid inhaler or why they should be taking a steroid inhaler? And it's having that conversation with patients about, what is going on in their airways, and that actually the treatment for asthma is inhaled corticosteroid. It's not salbutamol. Patients with well-controlled asthma, and the majority, probably well over 90% of patients, should not have asthma symptoms whatsoever and should be able to live a life freely without having to take their blue inhaler more than once a week at the absolute maximum.
I mean, you've obviously highlighted the major issue here, which is SABA overuse. And of course, if you're overusing your SABA, there's a good chance that you're underusing your inhaled corticosteroid. Why is that such a problem?
Well, I suppose the problem is that if you're not getting the steroid and it's not going into the right place, then you have that inflammation in your airways, which then drives that bronchoconstriction, which then leads to symptoms. Now, patients like taking the SABA, and I get that because it gives them instant relief. The steroid inhaler doesn't give instant relief, and it's a long-term thing. It's about talking to that patient that actually, if we can get you to take that steroid inhaler morning and night or once a day, it will reduce that inflammation in your airways. It will stop that bronchoconstriction. It will stop the symptoms. It will stop you waking at night. And also, what matters to them, it will allow them to, run that cross-country race or go swimming or run around with their friends or run after their grandkids. And actually, it's getting them to think about what symptoms they have from their asthma and how it's controlling their lives. Because as I say, I think we normalise it and people should be not having symptoms from asthma.
I think a lot of patients don't actually realise what our goals should be. If we think back to the SIGN guidelines, been around for years and years and years now, we're all very familiar with these sort of SIGN or British Thoracic Society guidelines, then they suggest that our goal for asthma care should be essentially 0 symptoms. It should be no cough, no wheeze, no daytime, no nighttime symptoms, no symptoms with exercise, no flares when you have illnesses. And I think maybe that message hasn't really got through, perhaps to us a little bit, but certainly to patients. And so I'm sure you're right. Lots of patients do just accept that they get some asthma symptoms and maybe we can help them a bit more.
Yeah, and I'd argue actually the message definitely hasn't got through to us because patients can't prescribe themselves, Saba. The only way they can get prescription is from us. If we are prescribing a blue inhaler every single month or 2 blue inhalers, it's our responsibility to stop that and work with the patient to get their asthma better under control. And I think one of my bugbears is that when we diagnose somebody with asthma, what do? We prescribe them a blue inhaler. And actually, that's giving out that message that blue inhaler is the most important inhaler. It's not. The most important inhaler is the steroid inhaler. So when I'm diagnosing somebody with asthma, I will always prescribe them a steroid inhaler first as a trial of treatment, unless they're very, very symptomatic. And if they're very, very symptomatic, they probably need a course of prednisolone. But unless they're very symptomatic, then I don't prescribe them a blue inhaler when I'm diagnosing the asthma, just to get them into that zone that this doctor is giving me a steroid inhaler. She said that this is the most important inhaler. She said that it's going to open up my airways, and she said that it's potentially going to stop me ending up in hospital or worst case scenario dying. So it's just really getting that message from the outset.
Okay, let's move on to question number 2. Tell me one thing that we need to know about that's going on in secondary care in respiratory disease.
Lots of exciting stuff happening in hospital. I will argue that a huge amount of respiratory care should be happening in primary care, but we now have access to biologics, which are medication for patients with severe or brittle asthma, which are given via IV or in infusions. And it's important that we recognise and identify these patients in primary care that may benefit from being referred into secondary care. And we know that so often that there is a delay in getting patients into secondary care. It kind of ties in with what I was saying before. So somebody who is over-reliant on the salbutamol inhaler, the majority of times that can be sorted with making sure that the patient knows why they're taking the inhaler, making sure that they know how to take their inhaler with inhaler technique, making sure that they know what to do in an emergency, and also tackling adherence of the inhaled corticosteroids. I know from talking to my secondary care colleagues, the majority of patients that are referred into the severe asthma clinic don't have severe asthma. They have severe adherence problem or severe overprescribing of salbutamol inhalers by their GP. So get those right. So once you've got that patient in, you've talked to them about what's going on with the inflammation in the airways. You've talked to them about adherence. You've checked their inhaler technique. You checked that they're on the right track, and they continue to deteriorate, need courses of prednisolone and or admissions to A&E, it's at that point that you need to pick that up and refer into secondary care, because biologics can be transforming for patients. It really can change their lives. And I had a patient copied me into a letter that they'd sent to their secondary care asthma team, and I was reading it this morning, and she said, I've spent most of my life unable to walk upstairs. I've been in A&E, I've been in resus, I've been in ITU. I'm now on biologics and my life is transformed. And it was a goosebump moment that actually there are things out there that can really help. But it's important that we don't clog up that system with patients that shouldn't be there and actually should be being sorted out in primary care with just some really good, basic, simple asthma care.
Simple things work. Right, question number 3 then. Tell me one thing that is pushing the boundaries of managing respiratory care. And I'm guessing we're going to stay on the asthma theme. So what does the future have in store for asthma?
Well, biologics, yes. But I suppose we need to start getting the diagnosis right for asthma as well. I think nationally, They reckon about 25% of patients on the asthma register don't have asthma. I started the podcast by talking about normalizing GTN sprays for patients with angina. It doesn't happen. Can you imagine a world where we didn't have accurate tests for diabetes, for cardiovascular disease, for strokes, for cancer, all the other long-term conditions, where we have this really clear diagnostic pathway? And for patients with asthma and COPD, it's just, well, there's a machine in the room, it's a bit dusty, just crack on. It might be wrong. You might end up on a register and end up on triple dose, high dose steroids with a risk of getting pneumonia and also not having your fibrosis diagnosed, but for whatever reason. And this is why what keeps me going, that those patients with respiratory disease deserve equity of care.
It feels like with the pandemic, practices have taken a little step back in their diagnostic abilities, because a lot of them, for obvious reasons, stopped doing spirometry at the start of the pandemic. I get the feeling that quite a significant proportion haven't restarted. Do you think that's a loss for practice, or do you think we're better off having this done through these diagnostic hubs then?
It's quite exciting about the idea of having diagnostic hubs for spirometry. And obviously, if we can get spirometry happening at more of a PCN level rather than at practice level, it cuts down that variability. It cuts down the fact that, you need training for the nurses or the healthcare assistants doing the spirometry, but also the doctors interpreting spirometry. And interpreting spirometry is not easy. I'm quite open about the fact that I failed respiratory physiology at university. It remains not something that I particularly enjoy doing. I'm better at it than I was then. But actually, a lot of doctors are not trained to interpret spirometry. There are big consequences for those patients. Wrong interpretation, not just for asthma, but for COPD as well. It has, implications for life insurance, mortgage, travel insurance. And actually, it's our job to really start to work together to think about how we can make sure that patients get that diagnosis right. Something that is emerging, and certainly at the British Thoracic Society conference that I was at a couple of weeks ago, there's a talk about using artificial intelligence to actually start to interpret spirometries, which I think is quite exciting. And there are trials going on about that at the moment. I know there's been a big push, certainly with QOF and the NICE guidelines, about making sure that we really have that good objective evidence of reversibility. That's great on paper. The actual reality in primary care, most practices don't have access to a pheno machine. We need good access to that, because you want to do the test there and then. You don't want it after they've started the steroids or, God forbid, salbutamol inhaler. You want to do it there and then when they've got that inflammation. And again, this is not boundary stuff, but the peak flow diary, really simple, really good instructions to the patient about why you're doing it, how to do it, using AccuRx, send it to them, take a photograph to upload. I've had more peak flow diaries back in the last couple of years than I have done in my entire career as a GP, because it's so easy to upload and actually reasonable quality as well. It's important not to forget about the good old peak flow diary.
Reminding us as we look to the future, don't forget the lessons of the past. Well, thank you, Katherine, for joining us today. It is worth having a look at the Primary Care Respiratory Society website. I'll put the link in the podcast description. Lots of really good resources for helping us manage respiratory disease in primary care on the website there. They've also got a national conference that happens every year. So that happens in September. Do check that out. And they're always on the lookout for more interested individuals. So do get in touch if you fancy doing a bit more with respiratory disease. So all it leaves me to say is thanks so much to Dr. Katherine Hickman for joining us today. It's been great to have you along.
Thank you very much.
That's a wrap for today, everyone. Thanks so much for joining us once again. Don't forget to check out all the stuff that's going on with NB Medical on the nbmedical.com website. You can always get in touch through the website. You can email on hottopics@nbmedical.com. We will be back in 3 weeks' time with the next podcast. We'll be doing another Just One More Thing interview, this time with Dr. Sam Merrill, who is a GP and an academic researcher into prostate cancer. He'll be sharing what's new and what we need to know about the condition. Look after yourselves, everyone. See you next time. Bye-bye.